Hi, I'm Dr. Stephen Liu, Director of Thoracic Oncology at Georgetown University. At ASCO 2025, Dr. Patrick Forde gave what I think is a very important update to CheckMate 816, a neoadjuvant immunotherapy study, really showing for the first time a survival benefit to this approach. As we remember, this was a phase 3 trial for patients with resectable stage 1B to 3A non-small cell lung cancer, where patients were randomized to receive standard neoadjuvant chemotherapy for 3 cycles, either alone or with nivolumab, PD-1 inhibitor. And what we'd seen before from this study was that the addition of nivolumab to neoadjuvant chemotherapy improved pathologic complete response rate from 2.2% with chemotherapy to 24% with nivolumab and chemotherapy. It improved event-free survival, giving it clinical benefit with a hazard ratio of 0.63. But what we didn't know until ASCO 2025 was, did this translate to an improvement in survival? The reason why this is so critical is we do know from other perioperative immunotherapy strategies that did improve survival, that the addition of immunotherapy, in this case, Keynote 671 pembrolizumab, the addition of pembrolizumab before and after surgery did lead to a survival benefit. While we know that the neoadjuvant component alone improved pathologic complete response, improved event-free survival, we really did need to see an improvement in overall survival to know that this was a viable strategy and that some patients could be spared that adjuvant component. And here at this meeting, we did see an improvement in overall survival. The median survival with nivolumab chemotherapy not yet reached. With chemotherapy alone, 73.7 months. That's an odds hazard ratio of 0.72. The addition of nivolumab improved the 5-year survival rate from 55% to 65%, cementing this as a viable option. With only 3 doses of neoadjuvant nivolumab improving outcomes, where should this be employed instead of a perioperative regimen? Well, that still remains to be determined. And there are likely some patients who do benefit from that adjuvant component and some that may not need further therapy, sparing them cost and potential toxicity. We did see some subset data. For example, those with PD-L1 positive tumors had a hazard ratio of 0.51 for survival, whereas those with a PD-L1 of less than 1%, the OS hazard ratio is 0.89, with confidence intervals that surrounded 1. The benefit clearly greater in patients with PD-L1 expression. We saw patients that had a pathologic complete response did very well. In fact, the 5-year survival rate was 95% with nivolumab chemotherapy. Those that did not achieve path CR, 56% with nivo chemo, 54% with chemo alone. Our patients who don't achieve pathologic CR, the ones that will benefit from the adjuvant component. This study is not designed to ask that. However, we have other trials ongoing that really will give us that answer. ctDNA also seemed to be relevant. Those that cleared ctDNA had better survival at 5 years, whether receiving chemotherapy or nivolumab chemotherapy. Those that did not clear ctDNA did have worse outcomes. Could this be potentially a factor to help stratify patients? I think as we go forward, we know that giving neoadjuvant immunotherapy in resectable lung cancer without an EGFR ALK alteration clearly improves outcomes, pathologic CR, event-free survival, and now overall survival. Now the question is, can we further improve outcomes with the adjuvant component? And we need a little bit more data and study design to answer that specific question.